We all have things that make us uncomfortable or even fearful. Perhaps it's the sight of a spider scurrying across the floor, the thought of stepping onto an airplane, or looking down from great heights. For most people, these fears cause momentary discomfort but are manageable. For others, however, these fears can become so intense and overwhelming that they dramatically impact daily life. This is the reality of living with a specific phobia. Welcome to our exploration of specific phobias, one of the most common yet often misunderstood anxiety disorders. Over the next 12 minutes, we'll delve into what specific phobias truly are, how they develop, the various types that exist, their symptoms, and most importantly, the effective treatments that can help those affected overcome their fears. Whether you're personally affected by a phobia, know someone who is, or simply want to understand this aspect of mental health better, this video aims to provide clarity, compassion, and practical knowledge about specific phobias. What are specific phobias? A specific phobia is much more than just a fear or dislike. It's a type of anxiety disorder characterized by an intense, persistent fear of a specific object, situation, or activity that generally poses little or no actual danger. When exposed to the feared stimulus, or even when anticipating such exposure, a person with a specific phobia experiences immediate and severe anxiety. What distinguishes a specific phobia from normal fear is both the intensity of the fear response and its impact on daily functioning. While most people might feel nervous about certain things, specific phobias involve fear that is out of proportion to the actual danger posed, cannot be reasoned away or explained logically, beyond voluntary control, leads to avoidance of the feared object or situation, persists over time, typically 6 months or more, significantly interferes with normal routines, relationships, or activities. According to the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, specific phobias affect approximately 7 to 9% of the general population in any given year, making them among the most common anxiety disorders. They can develop at any age, though many begin in childhood or adolescence. Specific phobias differ from other anxiety disorders like social anxiety disorder or generalized anxiety disorder in that the fear is focused on a specific object or situation rather than being more generalized. They also differ from normal developmental fears, which children typically outgrow as part of normal development. Types of specific phobias. Specific phobias are remarkably diverse, potentially involving virtually any object or situation. However, they're generally grouped into 5 major categories based on the DSM-5. Animal phobias involve fears of animals or insects. Common examples include arachnophobia, fear of spiders, ophidiophobia, fear of snakes, cynophobia, fear of dogs, and entomophobia, fear of insects. These are among the most common phobias and often develop in childhood. Natural environment phobias involve fears related to natural phenomena. These include acrophobia, fear of heights, astrophobia, fear of thunder and lightning, aquaphobia, fear of water, and nyctophobia, fear of darkness. The intensity of these phobias can vary seasonally or based on environmental conditions. Blood injection injury phobias include hemophobia, fear of blood, trypanophobia, fear of needles or medical procedures, and traumatophobia, fear of injury. These phobias are unique because they often cause a 2-phase vasovagal response, initial anxiety followed by a drop in blood pressure and possible fainting, a reaction not typically seen in other phobias. Situational phobias involve fears of specific situations like claustrophobia, fear of enclosed spaces, aerophobia, fear of flying, amaxophobia, fear of driving, and elevophobia, fear of elevators. These often develop in late adolescence or early adulthood and can significantly restrict mobility and independence. Other phobias include a wide range of fears that don't fit neatly into the above categories, such as emetophobia, fear of vomiting, choking phobia, loud noise phobia, lidrophobia, and various illness phobias. Some rare and unusual phobias include chromophobia, fear of colors, paganophobia, fear of beards, or omphalophobia, fear of belly buttons. It's worth noting that a person can have multiple specific phobias simultaneously. In fact, research suggests that approximately 75% of people with one specific phobia meet criteria for at least one additional phobia. Symptoms and impact. The symptoms of specific phobias typically manifest both physically and psychologically, creating a distressing experience that reinforces avoidance behaviors. When confronted with a feared object or situation, or even when anticipating such an encounter, individuals with specific phobias often experience physical symptoms that reflect an activated fight or flight response: rapid heartbeat, shortness of breath, sweating, trembling or shaking, chest tightness, dizziness or lightheadedness, nausea or stomach distress, chills or hot flashes, and numbness or tingling sensations. In blood injection injury phobias, these symptoms may be followed by a drop in blood pressure and fainting. Psychological symptoms include intense anxiety or fear, a sense of impending doom or danger, an overwhelming urge to escape the situation, feelings of unreality or detachment, and fear of losing control or going crazy. There's often a recognition that the fear is excessive or unreasonable, but this insight doesn't diminish the fear response. Children may express their fear differently, often through crying, tantrums, freezing, or clinging to a parent or caregiver. They may not recognize that their fear is excessive. The impact of specific phobias extends beyond the immediate fear response. The anticipatory anxiety, the worry about encountering the feared object or situation, can be just as debilitating as the fear itself. This leads to avoidance behaviors that can severely restrict an individual's activities and quality of life. For example, someone with aerophobia might miss important family events or career opportunities that require air travel. A person with cynophobia might avoid parks, certain neighborhoods, or friends' homes where dogs might be present. Someone with acrophobia might turn down an ideal apartment because it's on an upper floor. This avoidance can lead to significant life limitations, embarrassment, and social isolation. Many people with specific phobias report feelings of shame about their fears, especially when others don't understand the involuntary nature of phobic responses. Over time, specific phobias can contribute to lower self-esteem, reduced quality of life, and increased risk for other mental health conditions like depression. Causes and development. The development of specific phobias involves a complex interplay of biological, psychological, and environmental factors. While no single cause has been identified, several pathways to phobia development have been well documented. Direct learning experiences, particularly traumatic ones, can lead to phobia development. This is known as conditioning and occurs when a neutral stimulus becomes associated with a frightening experience. For example, being bitten by a dog might lead to cynophobia, or having a panic attack while driving could trigger amaxophobia. Observational learning or modeling can also contribute to phobia development. Witnessing someone else's fear response, particularly a parent or close family member, can teach a person to fear the same stimuli. This explains why phobias sometimes run in families even without genetic transmission. Informational learning involves developing fears based on information received about potential dangers. Media coverage of plane crashes, stories about dangerous animal encounters, or warnings about various threats can all potentially trigger phobias in vulnerable individuals. Biological factors play a significant role as well. Research suggests there may be an evolutionary predisposition to develop fears of certain stimuli that threatened our ancestors, such as heights, snakes, or spiders. These fears develop more easily than fears of modern dangers like guns or electrical outlets. Genetic factors also contribute, with studies of twins showing moderate heritability for phobic fears. This genetic vulnerability likely involves brain circuitry related to fear responses, particularly the amygdala and related structures that process threat detection. Neurotransmitter systems, especially those involving serotonin, norepinephrine, and gamma-aminobutyric acid, GABA, have been implicated in anxiety disorders including specific phobias. Personality traits may predispose individuals to phobia development. High neuroticism, behavioral inhibition, and anxiety sensitivity, the tendency to fear anxiety-related sensations, have all been associated with increased vulnerability to phobias. It's important to note that these factors usually interact. A person might have a biological vulnerability that is activated through a learning experience, or a traumatic encounter might have more impact on someone with a family history of anxiety disorders. Diagnosis and assessment. Diagnosing a specific phobia involves a comprehensive assessment typically conducted by mental health professionals such as psychologists or psychiatrists. According to the DSM-5, several criteria must be met for a diagnosis. The fear or anxiety is marked and out of proportion to the actual danger posed by the specific object or situation. The phobic object or situation almost always provokes immediate fear or anxiety. The phobic object or situation is actively avoided or endured with intense fear or anxiety. The fear, anxiety, or avoidance causes significant distress or impairment in functioning. The disturbance persists for 6 months or more. The symptoms aren't better explained by another mental disorder. The assessment process typically includes a detailed clinical interview exploring the nature of the fear, its onset and development, impact on functioning, and any treatment history. Clinicians may use structured diagnostic interviews or standardized questionnaires like the Fear Survey Schedule or the Specific Phobia Questionnaire to aid assessment. Self-monitoring tools, where individuals track their anxiety levels in various situations, can help clarify patterns and triggers. In some cases, behavioral assessment tests, BATS, might be used, where individuals are gradually exposed to the feared stimulus in a controlled setting while their anxiety responses are monitored. It's particularly important to distinguish specific phobias from other anxiety disorders with overlapping symptoms. For example, fear of crowded places could represent a specific phobia or be part of agoraphobia or social anxiety disorder. Similarly, medical fears need to be distinguished from illness anxiety disorder or somatic symptom disorders. The assessment should also screen for comorbid conditions like depression, substance use disorders, or other anxiety disorders, as these can complicate treatment planning and outcomes. Treatment approaches. Exposure therapy. Specific phobias are among the most treatable mental health conditions, with success rates often exceeding 80 to 90% with appropriate intervention. Exposure therapy stands as the gold standard treatment, with decades of research supporting its effectiveness across various phobia types. Exposure therapy involves systematic, gradual confrontation with a feared object or situation in a controlled environment. This process helps individuals learn that their feared consequences don't materialize and that their anxiety naturally decreases over time, a process called habituation. Several approaches to exposure therapy exist. Graded exposure, systematic desensitization, involves creating a fear hierarchy, a ranked list of feared situations from least to most anxiety-provoking, and gradually working through them. For example, someone with arachnophobia might start by looking at cartoon images of spiders, progress to photos, then videos, then viewing a spider in a sealed container, and eventually being in the same room with a spider. Flooding involves more rapid exposure to highly feared stimuli. While effective, this approach is used less frequently as it can be initially more distressing and may lead to higher dropout rates. Virtual reality exposure therapy, VRED, uses computer-generated environments to simulate phobic stimuli. This has proven particularly effective for phobias like fear of heights, flying, or public speaking, allowing controlled exposure when real-world exposure might be impractical or costly. In vivo exposure, or real-life exposure, is generally considered most effective and involves confronting the actual feared situation or object rather than imagined scenarios or representations. Regardless of the specific approach, effective exposure therapy typically includes education about the nature of anxiety and how exposure works, collaborative development of exposure exercises, prolonged and repeated exposures, prevention of safety behaviors or avoidance during exposure, processing of the experience after exposure. Exposure is often combined with cognitive restructuring techniques that help identify and challenge unhelpful thoughts contributing to the phobia. For example, someone with a fear of elevators might work on challenging catastrophic thoughts like, "I'll be trapped and unable to breathe," with more realistic alternatives. For children with specific phobias, exposure therapy is typically modified to be more playful and may involve parents as co-therapists. Reinforcement strategies like reward systems often complement the exposure work. Other treatment approaches. While exposure therapy represents the first-line treatment for specific phobias, several other approaches have shown effectiveness, particularly when used in combination with exposure. Cognitive behavioral therapy, CBT, extends beyond pure exposure by addressing the thoughts and beliefs that maintain phobias. This might involve identifying cognitive distortions like catastrophizing or overestimating danger, developing more realistic appraisals, and learning coping strategies to manage anxiety during exposure. Applied relaxation training teaches progressive muscle relaxation, controlled breathing, and other relaxation techniques that can counteract the physical symptoms of anxiety. These skills are often taught before exposure exercises begin and provide tangible tools for managing fear responses. For blood injection injury phobias, applied tension techniques may be incorporated to prevent fainting. This involves tensing major muscle groups to maintain blood pressure when confronted with phobic stimuli. Medication is generally not a first-line treatment for specific phobias, but may be used in certain circumstances. Beta blockers like propranolol can reduce physical symptoms of anxiety and might be prescribed for specific, infrequent phobic situations, like flying or public speaking. Benzodiazepines provide rapid relief from anxiety, but carry risks of dependence and are typically used only for short-term management of unavoidable phobic encounters. Some newer approaches showing promise include eye movement desensitization and reprocessing (EMDR) therapy, particularly for phobias with traumatic origins. Mindfulness-based interventions that focus on accepting rather than fighting anxiety sensations. Single-session treatments that combine multiple therapeutic techniques in one intensive session, often 2 to 3 hours. D-cycloserine, a medication that may enhance learning during exposure therapy when taken shortly before sessions. Technology-assisted treatments continue to evolve, with smartphone apps providing self-guided exposure exercises, virtual reality systems becoming more sophisticated and accessible, and augmented reality approaches beginning to show promise. It's worth noting that the effectiveness of any treatment depends on various factors, including the specific phobia type, its severity and duration, the presence of comorbid conditions, and the individual's motivation and engagement in treatment. Living with and beyond specific phobias. Managing a specific phobia extends beyond formal treatment and involves developing strategies for long-term maintenance and continued growth. While complete elimination of fear isn't always necessary or realistic, most people can achieve significant reductions in fear and avoidance that allow them to engage fully in life. Relapse prevention strategies are crucial for maintaining progress. This includes recognizing early warning signs of returning avoidance, having a plan for addressing setbacks, and continuing to practice self-directed exposures even after formal treatment ends. Many therapists recommend booster sessions at intervals following treatment to reinforce gains and address any new challenges. Self-help approaches can complement professional treatment or provide support for those with milder phobias. Books, online programs, and support groups offer education, exposure planning guides, and communities of individuals working through similar challenges. For family members and friends of those with specific phobias, education is essential. Well-meaning attempts to accommodate phobias by helping loved ones avoid feared situations can inadvertently reinforce avoidance patterns. Learning to provide support during exposure while not enabling avoidance represents a delicate but important balance. It's also important to address the shame that often accompanies phobias. Many people feel embarrassed about their fears or worry about being judged as childish or weak. Recognizing that phobias are legitimate mental health conditions, not character flaws or signs of weakness, can help reduce this stigma. With appropriate treatment and support, the prognosis for specific phobias is excellent. Most people experience significant improvement, often within a relatively short time frame. Even those with long-standing phobias can make remarkable progress at any age, demonstrating the brain's lifelong capacity for change and adaptation. Conclusion and resources. Specific phobias represent one of the most common, yet highly treatable anxiety disorders. While these intense fears can significantly impact quality of life, effective treatments exist that can help individuals reclaim freedom and confidence. If you or someone you know is struggling with a specific phobia, reaching out to a mental health professional is an important first step. Primary care physicians, psychologists, and psychiatrists can all play roles in assessment and treatment. Organizations like the Anxiety and Depression Association of America The American Psychological Association and the International Association for Cognitive Psychotherapy offer valuable resources, including provider directories, self-help materials, and support groups. Remember that seeking help for a phobia is not a sign of weakness. It's a courageous step toward confronting fear and expanding your world. With appropriate support and treatment, the limitations imposed by specific phobias can be overcome, opening the door to new experiences and possibilities. Thank you for taking the time to learn about specific phobias. Understanding is the first step toward compassion, both for ourselves and others navigating the complex landscape of anxiety disorders. No one chooses to have a phobia, but with effective treatment and support, everyone can choose how they respond to fear and find their path forward to a less restricted life.